Hello, everyone, and welcome to the Resources for Integrated Care webinar, Taking Charge, Evidence-Based Self-Management Programs. My name is Karen Chung. I am with the Lewin Group, and we're supporting the Medicare-Medicaid Coordination Office in the Centers for Medicare and Medicaid Services to ensure that dually eligible beneficiaries have access to seamless, high-quality health care. Before we get started, I want to go over a few pointers for using this webinar platform and help you troubleshoot any technical issues. First, for most of you, the audio portion of the presentation will automatically stream through your computer speakers. Make sure that the volume is turned up on your computer speakers to hear the presentation. I know some of you have also dialed in using your landline or telephone line, so make sure your lines are muted. If you're experiencing audio or technical difficulties, please use the Q&A pod on your screen or click on the Help button. Next slide, please. This is the fourth webinar in our 2017 Meaningful Member Engagement Series. Today's session will include presentations from experts, followed by a Q&A discussion between you and the presenters. This session is being recorded, and a video replay and the slide presentation will be available at resourcesforintegratedcare.com. And throughout the presentation, if you do have a question, please go ahead and use the Q&A feature on the platform and submit your question at any time. Also, if you would like a copy of the slides from today's webinar, you can actually download them right now under the resource list of this platform. Next slide, please. The Medicare-Medicaid Coordination Office, or MMCO, is developing technical assistance and actionable tools based on successful innovations and care models, such as this webinar. To learn more about current efforts and resources, please visit our website, resourcesforintegratedcare.com. You can also follow us on Twitter for more details. Our Twitter handle is @integrate_care. Next slide, please. This webinar is presented in part by the Lewin Group and Community Catalyst Center for Consumer Engagement and Health Innovation and supported through MMCO at CMS. We have a full agenda with 4 wonderful speakers, including someone who has participated in a chronic disease self-management program and is here to tell us more about her experience. I hope you'll take away some key learnings from each of our presenters, including key components of evidence-based chronic disease self-management education, how CDSME programs can help plans and providers to support patients in taking charge of their health and their life, how plans can ensure person-centered care, improve health outcomes, and control costs, how plans and providers can access CDSME programs in their states and communities. So we want to tell you more about CDSME and also give you the tools and resources to actually implement them. Next slide, please. We've outlined the topics for today's webinar here. We do want this to be an engaging experience, so we have a couple of polls in which we want you to participate. And our speakers will provide an overview of the chronic disease self-management program. Then a participant will share her experience, and we'll talk about the network of community-based organizations offering chronic disease self-management, which will help you get started. Then we'll show how a state and a health plan has partnered to offer CDSME to Medicare-Medicaid beneficiaries. We'll have some time for questions and answers, and we'll also like for each of you to complete a survey and provide us with feedback about this presentation. Next slide, please. Now, before I turn it over to our speakers, I'd like to field 2 quick polls so that we can better understand who's listening in on this webinar today. And here's the first poll. What is your primary role? Are you an administrator, director, or manager? Are you a clinician, educator, researcher, consumer advocate, care coordinator, family caregiver, or other? So I'll give it about 10 seconds. Go ahead and use your mouse and select a response. Great. Seems like we have a lot of administrators, directors, or managers listening in today, and a lot of clinicians as well. Wonderful. And now here's our second poll. In which setting do you work? Are you in a managed care organization, ambulatory care setting, long-term care facility, home care agency, community-based organization, consumer organization? Are you in academics/research or other? Looks like we have a lot of folks from community-based organizations and a lot of folks who selected other. That's interesting. I know we'll be talking a lot about community-based organizations today, so great. Thank you all for participating in the polls. It's nice for us to understand who our audience is. So at this time, I'd like to introduce our speakers. We're thrilled to have all of them here today. Dr. Kate Lorig served as director of the Stanford Patient Education Research Center and professor of medicine at the Stanford School of Medicine. She came to Stanford as a graduate student to develop and research an educational program that emphasized self-help skills for people with arthritis. The program became the Arthritis Self-Help course and was the prototype for the Chronic Disease Self-Management Program, the Diabetes Self-Management Program, the Positive Self-Management Program for HIV and Cancer, Thriving and Surviving Program, and Building Better Caregivers Program, and others. She has authored several books and many articles about arthritis, chronic disease in general, health education, and behavioral science. Linda McGowan will share her experience as a CDSME participant. Linda lives in Richmond, Virginia, where she is active in the community and believes in bringing programs and interventions to where people are. We're so glad that you're here to provide your perspective, Linda. Christy Kalinsky is a program officer for the Administration on Aging at the Administration for Community Living within the U.S. Department of Health and Human Services. Christy oversees ACL's Chronic Disease Self-Management Education Initiative. This initiative provides funding through competitive grants to organizations across the country to support the implementation and sustainability of chronic disease self-management interventions. And lastly, April Holmes is the coordinator of prevention programs at the Virginia Department of Aging and Rehabilitative Services. April manages chronic disease self-management education programs delivered by area agencies on aging throughout Virginia. April has worked for more than 20 years in disability and aging. And Dr. Lorig is our first presenter. So I will turn it over to you now, Dr. Lorig.
Thank you very much. I'm absolutely delighted to be here today. Can we go to the next slide, please? Can we go to the next slide? Thank you. We missed a slide. That's what we want. Thanks so much. Some of you may know, some of you may not know that the Chronic Disease Self-Management Program and all the evidence-based programs that we've developed at Stanford University over the last 30 or plus years have recently moved to a new home, which is a Self-Management Resource Center. And this new center basic mission is exactly the same as it was at Stanford, that to get evidence-based programs to people throughout the nation. And same programs, basically same people, new logo, new website, etc. So just wanted to start there because I know people are a little confused. The Patient Education Research Center at Stanford is now closed. The Self-Management Resource Center is now open. Next slide, please. Next slide, please. Thank you. So, why is chronic disease self-management important? Most of the facts on this slide you all know. Boring. 1 in 4 adults have multiple chronic conditions. 3 in 4 adults over 65 have multiple chronic conditions. But I think what we don't think about a lot is that people with chronic conditions live most of their time outside of the healthcare system. We think that probably 99% of the time outside of seeing a doctor in the hospital. And how they live during this time greatly determines their quality of life, their health, and also their utilization of the healthcare system. Unfortunately, we have very little in the way of standardized ways of helping people with chronic disease live their lives to the maximum benefit during this time. And the Chronic Disease Self-Management Program was really developed to do that. We looked at what people with chronic diseases need to know and do, and we found that across diseases, 80 to 90% of the strategies are the same. And so it's those strategies which we teach within the context of the Chronic Disease Self-Management Program. Can we go to the next slide, please? So what is it? It's a program that's 6 weeks, 2.5 hours a week. The program is given in the community. This picture that you see is actually a course given in George's Garage in San Diego. Now, we don't have terribly many courses given in garages, but I think it's a good indication of going to where people are and making it convenient for them. Generally, courses are given in senior centers, in libraries, in public schools, rooms, church basements, etc. Programs are led by 2 peer leaders. That means that most of our leaders are actually patients themselves. We have a standardized program for training leaders. It's 24 hours given over 4 days. Leaders teach from a very structured teaching protocol. So they're not kind of left on their own to do whatever they want, but have a very, very structured. In fact, many of our leaders will tell you it's too structured. But that's the way that we can pretty well know that if a program is given in Virginia or the American Virgin Islands or in Guam or in Ukraine, it's the same program. We have standardized materials. Generally, in a workshop, we will have 10 to 15 people with different chronic conditions, most of them with 2 or 3 chronic conditions. One of the things that makes this program very different is that we teach several different topics every session. And the reason we do that is because people don't learn by getting great big gulps of things. They learn by getting little bites and then adding to them. When people go to school, they don't have 3 months of reading and 3 months of writing. They have a little bit of reading and a little bit of writing every day. We follow the same thing. So the same topic may be revisited 4 or 5 or 6 times. What makes the program culturally appropriate is that it's self-tailoring. And what do we mean by that? It means that we tell people general things about exercise and about nutrition and about sleep and about pain. And then we help them figure out how to use this within the context of their own lives. So we never tell people what to do. We help them get started in doing things that are helpful for them. Finally, all of our programs, I should say almost all of our programs, have been evaluated in randomized trials, and those that have not been evaluated in randomized trials have been evaluated in a pragmatic trial. And these trials go from as long as 2 years. Next slide, please. So what do we teach? We teach people how to deal with symptoms, because what people are concerned about are symptoms. They're concerned about pain, shortness of breath, stress, depression, disability, sleep. So we actually teach about how to manage symptoms. We also teach a bunch of self-management tools such as exercise and healthy eating, medication management. We don't talk about specific medications, but we do talk about medication management, communicating with family and friends, communicating with health professionals, and then 3 very key skills in self-management: action planning, actually doing something, not just learning about it. Problem solving. In this case, we teach a formal problem-solving process so that the next time a problem comes up, people have a way of dealing with it. And finally, decision-making. And again, we teach a very formal decision-making process because people with chronic diseases have to make many, many decisions every day. And when they make decisions, we want them to be able to make informed decisions. Next slide, please. let me talk about a couple of studies now. I won't bore you with hundreds of these, but this was a study that was done a few years ago. It was done in 22 different sites across the United States. It was done, we had people participating in both English and Spanish. There were more than 1,000 participants. The study was a year long. 40% of the participants were underserved minorities. And this is a study that focused on better care, better outcomes, and lower costs, the triple aims of healthcare. Next, please. So as we look at these triple aims, what was the better patient experience? Well, people had less medication, not less. They had better medication adherence. They increased their minutes of exercise, and they improved their communication with physicians. Remember, this is 1,000 people over 1 year. Next, please. They also had improved symptoms. They had less depression, less fatigue, improved quality of life, fewer unhealthy physical days, fewer unhealthy mental health days, improved self-assessed health, and for those people with diabetes, they had lower hemoglobin A1C. And by the way, these are all published studies. People can contact me or they can look on our website and can look at kind of all the details. This is pretty high level. Next, please. There were also less healthcare utilization. There were emergency room visits were reduced by 5%. Hospitalizations were reduced. And a cost study suggested that the potential net savings of about $350, $360 per participant for the people in this study. And the national savings, if 5% of the adults took this program, would be over $3 billion. Since that time, we've done a couple of more cost studies, and the cost studies generally come in just about in this same range about the savings in healthcare utilization. So I'm fairly convinced that these figures are now real. We've recently done a study with a major insurer, and their data on costs came in right in this same range, and they were using data off claims data as opposed to self-report. So I'm feeling pretty positive about these data being pretty valid. Next, please. So one of the things that we're asked about, and I know a lot of you deal with, are people with severe mental health problems. While we were doing this larger study, people in the state of Michigan called me and said, could we do this looking at a group of people being served by mental health centers throughout the state? And we said, sure, we could do this. These people were not included in the data I just showed you. This was a little side study that was done at the same time. And it was a 6-month study. You can see that kind of how these people break out as far as having major mental health issues. Obviously, this is more than 100% because people had more than one condition. Next, please. Again, the demographics of this group, they're younger, obviously. You can see they had 5 conditions. Those were both mental health and physical conditions, and very high percentage of both Medicare and Medicaid users. Next, please. Again, over 6 months, this group saw decreased fatigue, decreased depression, improved medication adherence, improved amount and quality of sleep, and improved communication with providers. So again, we're seeing, again, in a group of people with severe mental health problems, pretty much the same outcomes as we saw in the other. This leads us to the thought that this program is for people with any sort of chronic illness, mental or physical. Around the country, generally, these people are put into programs together. Sometimes they're separated, sometimes they're together. but it seems to work pretty well across both mental and physical conditions. Next, please. The program is now available in 25 states. We have more than 2,000 active trainers and 10,000 leaders. The program is available in 14 languages, and it's also available in some other formats. It is available in a program that can be done through the mail. It is, this says rural and telehealth programs. No, there are no telehealth programs. There is an internet program. This slide is incorrect. There are no telehealth programs. To find a program near you, excuse me, my screen just went dead. There we go. To find a program near you, there's a wonderful website. It is from the Evidence-Based Leadership Council, and so if you just go to EBLC programs, you can see the whole thing here, but if you Google EBLC programs, you'll probably find that there's an interactive map, and you can find not only the chronic disease self-management program, but all 19 or 20 of the Evidence-Based Leadership Council programs on that website. And if you want more information specifically about the programs given by the Self-Management Resource Center, take a look at our website. We'd be happy, or give us a call. We'll be happy to talk with you. And I think this might be the end, but let's see. We have one more? I guess we have one more. The other programs that we're doing are the other evidence-based programs are arthritis, falls prevention, diabetes self-management, pain self-management, positive self-management for those folks with HIV/AIDS, cancer thriving and surviving, and a soon-to-be-released program, Building Better Caregivers. So you'll see there's a whole wide range of evidence-based programs that at least we think that you all may want to consider. And next, please. All right, Linda, you can now tell people the real truth. Thank you so much.
Hi, Linda. Hi. Thank you for coming here to talk about your experience as a CDSME participant. So Linda attended a workshop, I think it was the spring of this year, correct?
That's correct.
In Richmond. So what was it that made you decide to attend a workshop?
Well, I have two chronic conditions, diabetes and hypertension, and I decided I wanted some more current information about the diseases itself, but also I wanted to learn how to be more self-empowered, more active in my management of my diseases, which would be a big thing, when I first started attending the workshops.
Really? So you were interested in managing your condition better?
I knew there had to be a way, there was something I needed to do.
Okay. So what are some things that you learned or thought were valuable about attending the workshop?
Well, the biggest thing, which was a surprise to me, was how valuable the support group in and of itself was. Even though different people were dealing with different diseases, they all were saying the same thing. I took control. I was depressed, but once I got active, I stopped feeling better about myself. And I realized I had been overlooking that part of the issue. The other part was being an active manager, learning how to be active, how to be proactive in the whole process of decision-making.
Great. Do you remember anything about the action planning, how that worked for you?
Well, I learned how to problem solve, how it overflowed in other areas of my life, too. I began to identify problems and make lists and pick out options and see if they work. Then if that didn't work, I would try something else.
Mm-hmm.
And that, to me, was the active management basis for me. That really kind of broke that resistance in my head about being able to do anything about the disease.
So a practical approach to dealing with
problems.
A practical
approach, yes.
Okay. So how has it affected you to have attended the workshop, do you think?
Well, I think there's no rubber stamp in regards to how individuals can manage. their own diseases. The disease is itself, okay? But you have a responsibility to take control of what you need to do in management. So I really began to understand that I learned how to be positive. I had a lot of depression with the diabetes, and I'm still working on getting in control of that and doing some things to help put me in control of that. And I'm a positive person, and I'm an active person. To me, that's proactive.
Yeah. And didn't you tell me something about exercise?
Oh, yeah, that's a big thing. I hated going to the gym. But that was part of my action plan. Go to the gym. And it took me 2 or 3 visits to 2 or 3 gyms to find one that was non-judgmental. You worked at your own pace. There was nobody there making you feel bad about yourself. And I've been at it now for about 3 to 4 months.
Oh, that's great. Congratulations.
Thank you. Thank you very much.
So considering the audience, we've got a lot of like administrators on, and some people are in healthcare or health insurance kind of companies. Do you have any comments you wanted to make to them about this?
I think the comments have been said. We need to get out there where the people are. We need to go to the recreation and park centers for the children, the schools for the children, senior centers, and reach out to doctors and nurses and help them understand the value of promoting chronic disease self-management for the individual, the patient, empowering the patient.
Great. Thank you, Linda. And now Christy Kolinsky will take over and talk about it from the perspective of the Administration on Community Living.
Thank you, April and Linda. And Linda, you really just hammered home why we invest in these programs at the federal level. Thank you so much. So throughout the course of my presentation, I'd really like to demonstrate how the Administration for Community Living, or ACL, has made major investments in these programs. I'd like to highlight the breadth of availability of these programs and also just increase awareness about the availability of experienced community-based providers that you all can partner with, if you aren't already, to offer these programs. So I'd like to begin today by giving you a brief introduction to the Administration for Community Living. To those of you who aren't familiar, our mission is to maximize the independence, the well-being, and the health of older adults, people with disabilities across the lifespan, as well as their families and caregivers. And we really have a commitment to one fundamental principle, and that's that people with disabilities and older adults should be able to live where they choose, with the people they choose, and participate fully in their communities. Next slide, please. So in direct alignment with our mission to maximize independence, well-being, and health, ACL has supported chronic disease self-management education, or CDSME, and other evidence-based programs for more than a decade. And really the powerful evidence behind the CDSME programs, which Kate highlighted earlier, is what fuels this investment. Federal resources for these programs have significantly declined over the past 5 years as budgets have gotten smaller and tighter. So supporting programs with proven outcomes is really critical. We want to be sure that we're investing our limited resources in programs that we know work and have a benefit for participants. Through discretionary grants, we currently support 20 organizations, including 5 tribes, to expand access to and develop a sustainable infrastructure for evidence-based CDSME and self-management support programs. And the programs that were developed at Stanford and are now housed at the Self-Management Resource Center are offered by all of our grantees. Because of the significant investment by ACL, as well as other federal CDC invest in these programs, state and local partners, there's delivery capacity in communities across the country. So later in my presentation, I'll once again highlight the program locator that's available on the Evidence-Based Leadership Council website, and that will allow you to identify the licensed organizations in your area. Next slide, please. So I know Kate highlighted the CDSME National Study, but I think it's important to emphasize this study for 2 reasons. So first is the study demonstrated the value of the program with respect to impact on both patients, So the improved health, improved depression symptoms, quality of life, et cetera, as well as the impact on healthcare providers and payers. So we saw better care through improved communication, medication compliance, as well as decreased costs. So the outcomes, the participant outcomes, as well as the impact on the healthcare system are, of course, very important. Additionally, this study evaluated the effectiveness of the intervention in community sites across the country. So this was a real-world, non-research setting and found results that were consistent with the original research. So this tells us that community-based organizations are delivering high-quality programs, and we can be confident that participants are indeed benefiting. And that gets back to the information that Kate had shared earlier about it being a highly scripted program with rigorous training. We can be sure that programs, regardless if it's in Virginia and Richmond or in George's Garage in San Diego, that participants are getting the same intervention. Next slide, please. So the value of the CDSME for participants. So as I mentioned earlier, CDSME programs have significant value for both participants and healthcare providers. With respect to participants, CDSME is patient-centered. It builds a primary role for patients in understanding and managing their own health conditions. I think that Linda said, I wanted to be activated. I wanted to be more active in taking charge of my health. And that really speaks to that patient-centered aspect. It also facilitates active engagement with healthcare providers. So patients are coached in becoming a full member of their healthcare team with enhanced partnerships with providers. The interventions also build mutual support through an interactive environment to increase confidence and the ability to manage health and maintain a fulfilling life. So that's where the self-efficacy component comes in. People have the tools, the skills, and the confidence to actually carry that out. CDSME results in measurable and positive effect on physical and emotional outcomes and health-related quality of life. Both Kate and I have covered that. The participants also become more physically active and maintain this activity over time, despite any condition-related barriers. And Linda spoke to that as well about, not really enjoying exercise very much, but being more activated and taking that on as a result of the program. And then finally, and I think this is a really key point to emphasize, when workshops are provided by a community-based organization, it can be a gateway to additional supportive services. There's considerable opportunity here to impact social determinants of health, and these are the types of programs and services that, in addition to self-management programs, that community-based organizations either directly provide or can provide linkages to. Next slide, please. So for providers and payers, in addition to the participant outcomes that have already been discussed, there's also significant value with respect to improved health status, which translates to better scoring on quality and performance outcomes. When we look at HEDIS, Medicare Stars, CAHPS, et cetera, there's an ability to link that with with member participation in these programs. Activated patients who are effective self-managers are also likely to report higher satisfaction with their provider or insurer. This can lead to improved patient or member retention. And also referring to and or paying for these programs can help attract new members and distinguish a provider or a payer from others in their market. And we've seen this play out in some states where a particular plan begins offering self-management and other evidence-based programs, and suddenly there's interest from other payers because they too want to be able to add that additional or offer that additional benefit for their members. Next slide, please. So as I noted earlier, ACL has invested millions of dollars in developing a national delivery infrastructure for CDSME programs. And while you can certainly choose to build it internally versus buying it from a community-based organization, there is inherent value that comes to partnering with community-based organizations. So these organizations have experience delivering the intervention. Offering health promotion programs is not new to them. Area agencies on aging, for example, senior centers, they deliver disease prevention and health promotion programs on a regular basis. They have processes in place to assure quality. They often are doing fidelity checks. They're collecting data and they're analyzing that data or reviewing that data to ensure quality. They also have the ability to leverage efficiencies with respect to training, ordering materials, deploying leaders, etc. They also have the capacity oftentimes to train new leaders to account for either expansion of a program or potentially attrition of leaders if there's turnover. And as I mentioned before, community-based organizations are a trusted community resource. So beyond CDSME programs, these organizations are well known and valued in their communities. Many also provide or can help individuals access long-term services and supports that directly impact various social determinants of health. So if we look at food security, transportation, housing, et cetera, these are all areas that community-based organizations are experts in. Next slide, please. So I wanted to provide an example of a community-based organization who's partnering with a dual plan. So the Healthy Living Center of Excellence is in Massachusetts. They're a 90-plus member provider network of community-based organizations delivering CDSME as well as other evidence-based programs. And they are partnering with Senior Whole Health, which is a dual-eligible health plan. So Senior Whole Health pays the Healthy Living Center of Excellence for any member who attends CDSME as well as other evidence-based programs that are under the umbrella of the Healthy Living Center of Excellence. And I should say that the Healthier Living Center of Excellence is under the umbrella of Elder Services of the Merrimack Valley, which is an area agency on aging. So Senior Whole Health members find their way to workshops through a variety of mechanisms. Sometimes they self-refer and they collect data to learn who an individual's insurer is, so that way they can report back to Senior Whole Health if they've engaged one of their members in a workshop. They're also referred by Senior Whole Health providers and case managers. And they also use internal registries, and the Healthy Living Center of Excellence conducts the outreach to these registries to engage members in workshops. Next slide, please. So I did want to draw your attention to the CDSME Program Locator. I know Kate mentioned this during her presentation. I've listed the web link there as well and a screen grab, and you can see that I simply put in my home zip code in Fairfax County, Virginia, and then we've got the pins that popped up, and I believe I did a 20-mile radius, either a 10 or a 20-mile radius of my home, so a really convenient way to access licensed organizations by program in your area. And next slide, please. So to learn more, Kate, of course, told you about the Self-Management Resource Center. They have an excellent website. The Administration for Community Living funds a CDSME National Resource Center. They have a number of tools and resources and information on the programs. And then the Evidence-Based Leadership Council is also another great resource. I also wanted to call attention to a recently released ACL issue brief on CDSME that you may want to review. That's available at acl.gov under the Aging and Disability in America tab. Last slide, please. Okay, so in summary, we've had significant federal investment in CDSME programs. We know that programs have proven participant outcomes as well as considerable value for providers and payers. And finally, there are experienced, licensed organizations throughout the country, and I encourage you to partner with them to impact the health of the individuals who you serve. Thank you very much, and now I will turn it over to April Holmes.
Well, thank you for this opportunity to talk about CDSME for Medicaid beneficiaries. participating in Commonwealth Coordinated Care Plus through Virginia Premier Health Plan. This presentation will demonstrate how CDSME is being offered by health plans serving dual eligibles by partnering with a state agency, that's us, and using our mechanisms to facilitate referral and billing. We're fortunate to be an ACL grantee, so we're very familiar with what Christy just talked about. Next slide, please. First, a little bit about our agency. The Department for Aging and Rehabilitative Services, or DARS, is a Virginia state agency that provides and advocates for resources and services for older Virginians and adults with disabilities. One of the many things that we do is administer Live Well Virginia, our state CDSME program. The CDSME programs are coordinated for DARS at the Virginia Division for the Aging. Next slide, please. CDSME was first brought to Virginia in 2005 by the State Health Department. And thanks to generous grants and support from the Administration for Community Living, DARS has been able to offer CDSME to increasing areas throughout Virginia since 2010. This slide shows a time frame of the grants. We're currently in year 2 of the 2016 Prevention Public Health Fund grant. And I'm pleased to announce that DARS has just been notified that we were awarded a 2017 Falls Prevention grant as well. Next slide, please. CDSME is delivered at the regional level by Area Agencies on Aging, or AAAs. These local programs handle all aspects of program delivery, from leader recruitment to marketing to building local partnerships for sustaining the program. Under DARS coordination and with the support of ACL funding, CDSME is now offered directly in 19 Area Agencies on Aging, which are listed in black. Those listed in green are, quote, satellites of other programs, which means that the neighboring AAA operates the program by providing leader training, fidelity monitoring, mentoring, and other support. We offer CDSMP, or the Chronic Disease Self-Management Program, Diabetes Self-Management Program, and in limited areas also offer Cancer Thriving and Surviving and the Chronic Pain Self-Management Program. Workshops are provided on a wide array of settings, including clinics and health systems, community and faith-based organizations, homeless shelters, behavioral health and substance abuse recovery programs, and prisons and detention centers. And with the current grant, we're especially reaching out to people with early-stage dementia and their caregivers. Next slide, please. Oh, you've got it. Okay. To date, since our agency first started with CDSME, there have been 1,066 workshops with 13,499 people enrolled and 10,326 of those completing, and that is attending at least 4 of the 6 sessions. Over time, Virginia's completer rate has averaged 76%. This picture shows a typical workshop scene with participants contributing ideas and leaders writing them on an easel pad. As Kate explained, there's a lot of that in the workshop. Next slide, please. This graph was drawn from a database maintained by the National Council on Aging that tracks attendance and participant demographics. It's showing the type of chronic conditions reported by workshop participants. In Virginia, the most commonly reported individual condition is hypertension, with arthritis and diabetes second and third most common. But the most striking statistic is that 57% of participants reported having 2 or more chronic health conditions. So we're definitely reaching individuals challenged by multiple chronic diseases. Next slide, please. DARS is partnering with Virginia Premier Health Plan to provide CDSME to its members in Commonwealth Coordinated Care Plus, or CCC Plus. Virginia Premier is a nonprofit health plan headquartered in Richmond, Virginia. Previously, Virginia Premier served dually eligible beneficiaries in the Commonwealth Coordinated Care Program, which is part of CMS's Financial Alignment Initiative. Currently, Virginia Premier is one of 6 MCOs offering coverage under Commonwealth Coordinated Care Plus, into which the Commonwealth Coordinated Care was absorbed. CCC Plus is a statewide Medicaid-managed long-term services and supports program to serve individuals with complex care needs. 114,000 of the individuals to be enrolled in CCC Plus are also dually eligible. Next slide, please. We first started talking in 2015 to health insurance companies when DARS made presentations to the health plans about the benefits of chronic disease self-management for its members. Things really took off when the state Medicaid agency, the Department of Medical Assistance Services, or DMAS, included CDSME in its request for proposals to health plans proposing to offer benefits to CCC Plus members. In fact, DMAS strongly encouraged health plans to partner with us to offer CDSME as an enhanced member benefit. Virginia Premier took them up on that suggestion and will be the first CC Plus plan in the state to offer CDSME. Next slide, please. So DARS and DARS and BPHP, or Virginia Premier, just signed a contract and are poised to embark on this new venture. Key to the process is Virginia's No Wrong Door system. No Wrong Door is a virtual system and statewide network to help individuals access services and supports. In brief, this is how the referrals will work. Virginia Premier will use software tools of our No Wrong Door system to refer individuals to the AAAs. This may also include referrals for a range of services provided through AAAs, such as home-delivered meals, as well as the CDSME. Now, Christy mentioned some other services that are available through community-based organizations, and this system can help people access that. When the referral goes to the CDSME program, the local coordinator accepts the referral and contacts the individual to enroll him or her in a workshop. Once the person attends, the local coordinator tracks the attendance using the No Wrong Door tools. Those tools generate monthly reports that are used for DARS to bill Virginia Premier and in turn pay the AAAs. Next slide, please. We're very excited about this partnership that will yield advantages for both Virginia Premier and DARS. For Virginia Premier, the advantages include having one hub that stars in the No Wrong Door system for connecting to CDSME programs throughout Virginia, the improved health outcomes for participants as described by Kate, savings in hospitalization costs for members, and access through No Wrong Door to a wide range of potential services and supports for its members. For DARS, it's an opportunity to reach a high-priority population, Medicaid and dual-eligible beneficiaries with long-term care needs. Also, of course, payment from Virginia Premier supports our goal to sustain the program long-term. And through Virginia Premier utilization data, we hope to learn more about health outcomes and costs for participating members. Next slide, please. So this will be a win-win-win situation for Virginia Premier, DARS, and most importantly, the beneficiaries with chronic health conditions. So we offer the following takeaways for consideration. CDSME is a valuable resource for your members, and often there's a pre-made product available, as Chrissy described. Many states have an existing infrastructure for delivering the program and long experience with CDSME. So there's no need to reinvent the wheel. CDSME can make a significant difference for your members' capacity to manage their health and, as a result, improve their health status. Finally, an investment in CDSME for your members can result in significant health care cost savings. I'd like to conclude by reading some comments offered by our partner, Virginia Premier. We pursue this program for our members to help improve their outcomes by empowering them to live healthy on a daily basis. The CDSME program is promising as it is evidence-based, so we are looking forward to positive results for participating members. In addition, the idea of having someone who's living with a chronic condition to mentor and share their experience with our members appeals to Virginia Premier. By empowering our members to better manage their own condition, this program will help members make good choices and hopefully become better healthcare consumers as a result. We will use HEDIS rates and ER and hospitalization data to measure improved outcomes. Additionally, patient satisfaction will be gauged by continuing attendance in the program. So that ends my part of the presentation, and thank you for your attention.
Fantastic. Great. Thank you so much to all our speakers, Dr. Lorig, to Linda, Christy, and April for your presentations. We learned about CDSMP, and we've received a lot of great resources related to it. And we heard from Linda, who experienced the program firsthand and can attest to its value in self-empowerment. We also learned about how to partner with community-based organizations to offer CDSME and how this can really begin addressing social determinants of health. And then April gave a really nice example of how plans and providers partnered to offer CDSME as an enhanced benefit for members. So we now have some time for questions. Go ahead and type in your questions into the Q&A pod, and we will get through as many as we can during this session. And maybe I will start with some questions for Dr. Lorig. Dr. Lorig, how does one get training or certification in chronic disease self-management program?
There are several ways of doing this. If you want to train leaders, you contact the local organizations in your area, which you can find by looking on the Evidence-Based Leadership Council website. You can always call us at the Self-Management Resource Center or send us an email. We also do training of master trainers, so leaders teach participants, master trainers train leaders. There are about 30 master trainings given in the United States each year, and we can help you find one. Maybe we can help you find one near you. We also do about 5 of them a year here in California. So there's a lot of different doors, and I think probably the best thing to do is just, you can even send me an email. I'm just Kate at selfmanagementresource.com, and then we can, depending on what you want, we can help direct you to where you want to be.
Great, thank you. I have a question for Linda here. Linda, have you been able to use the strategies you learned in the program to teach and empower others?
Yes, I have. I've talked to family members, and I've also used it in my own personal life, dealing with other big issues that I had not taken charge of, have not been active in. So the whole decision-making process was big. The whole concept of this type of workshop, I have been sharing with people as I come in contact with them, yes.
Great, that's nice to hear. And I have 2 specific questions that are related, I think, to Christy and April's examples. So are participants with or without the senior whole life insurance in a class together? And if so, are those without senior whole life insurance billed a fee to participate? And then relatedly, I think in April's example, does Virginia charge non-health plan members to attend CDSMP classes? So both related to billing.
So for the example of Senior Whole Health in Massachusetts, I'm speaking as a program officer for their grant, and clearly I'm not on the ground in Massachusetts, but it's my understanding that, yes, there's a mixed class of individuals who have both Senior Whole Health as their insurer, as well as, other members of the community. I do know that in Massachusetts, Elder Services of the Merrimack Valley and their Healthy Living Center of Excellence uses, braided and blended sources of funding to support their workshops. So depending, they have a couple of contracts. So if a participant happened to fall under one of their contracts, they would get billed that way. They also have grant funds from the Administration for Community Living that supports workshops, and I think also some state-based funding as well. I don't know that participants are billed or are paying a nominal fee or anything like that if they aren't covered under a contract. I do think those other sources of funding likely pick it up.
And I'll just add to that from Virginia, because we have grants and we have other sources of funding, we don't have to charge participants, but when those sources dissipate, we'll have to be charging for participation in the workshops.
Thank you. Another question that is pretty specific to the program, how and by what method are participating members reporting back to their primary care physicians for continuity of care? I don't know if anyone has a sense of that.
This is Kate, and I can give one answer. that after the fifth session of every workshop, we ask participants to write letters to their physicians or to contact, or emails. It's more emails today, telling them about the workshop and what they've gained or what they haven't gained, if that's the case. So we actually do have a small formal feedback loop to do that.
And this is Christy. I would add that I know of some examples where, Kate mentioned that feedback loop, and that's so important. So, and I know at least one example where, some of the action planning that Kate referenced in her presentation, that, with participant consent, of course, participant action plans can be shared with the provider and documented in the electronic health record so that there's that continuity of care following the 6-week duration of the workshop. And, I know for our community-based organizations, particularly those who have contracts with healthcare providers or payers, they're at a minimum documenting participation and completion in the workshop.
And this is April. We do use that, what Kate was talking about in the 5th session, and sometimes people bring those back and read them and share them with the group. And some of the AAAs have initiated additional steps for the participant to provide feedback to their provider, like a form letter that they can add their information in. I've learned this, and this is what I've gained from it. So we go a little beyond in some areas.
Mm-hmm. And then another participant had a question. How do we get physicians and providers to understand the importance of encouraging their patients to attend these CDSMP workshops?
Let me comment a little bit on that. I think physicians actually do understand the importance. I also know that they are incredibly short on time, and that the second they start talking about a workshop, it costs them 3 to 5 minutes, and they don't have that much time. And so what we've done is we've gone to having the physicians tell people about the programs through the patient portal in the electronic medical record. We did an experiment at Stanford last year where everybody with a chronic disease in a clinic was sent an invitation to attend a workshop in various different modes. And in fact, we had a third of the entire clinic population respond. So I think the issue is not how do we get them to know that it's important. They do know it's important. I think the real issue is how do we get to patients in the healthcare setting without infringing on physician time. And I think that there are various ways of doing that, but I think that's the challenge.
And I would add to what Kate said, there's a geriatrician in Massachusetts who's been a longtime champion of these programs, and he has said recently that when he's presenting to healthcare providers or payers on behalf of the programs, either in Massachusetts or nationally, he won't do it unless there's a participant champion with him. So it takes me back to Linda. We need more Lindas, or for community-based organizations, we need to find our Linda and bring them with us when we're presenting these programs. And a couple of the other strategies I know is to continually be in front of providers, that it's not a one and done. I've dropped off a brochure, I've handed you a flyer, and now you'll refer. We need multiple touch points, as well as looking at other staff than the healthcare provider to make the referral. Oftentimes, I know in my own experience with my healthcare provider, I spend more time with the medical assistant often than I do with my healthcare provider. So looking at other key contacts within the practice beyond just the provider who may have more time, or who also have that trusted relationship with the patient.
This is April, and I would second what Christy was saying. That's been an issue here. We have regular conference calls with our local programs and at the state level, and we have special conference calls about particular topics that were identified by the programs. And the first priority was how to recruit enough participants. The second priority is getting practices to refer. And we'll be talking about that. And speaker on our next conference call will be someone who works with our Quality Improvement Network, who works with practices and has a lot of good ideas to share. And individual AAAs have had varying degrees of success. Some of them have a great relationship with the practices, and the practices have taken the ball and run with it. But I would agree that sometimes it's another person besides the busy doctor, like the practice manager, that you want to talk to, or maybe a nurse.
Great. And on a related thing, do you have suggestions for recruiting and retaining volunteer leaders for this program? One participant in the webinar says leader turnover is a huge issue for our organization.
What we found, and I think it's borne out by national results too, is that personal contact is the most effective, like Linda talking to other people, the local coordinator going to meet with a group at a senior housing residence or a senior center, and doing a session 0, which is an sort of a sample of the workshop so people can see what it's about. I think that helps too.
I think that in recruiting leaders, that every time we did loads of public presentations, and every time we'd say, you can come to the workshop, and by the way, if you'd like to teach it, put a star by your name. And then we'd call the people up and talk to them. You also need to be careful, because you end up choosing people like you or choosing people you like. And sometimes some of the best leaders are not like you and are not people that you particularly like, but they serve their own communities exceedingly well. So sometimes you have to suspend judgment. I mean, you obviously keep your judgment about whether they can keep fidelity and whether they're going to show up. But some of the other things you need to suspend judgment a little bit about. And the way you find leaders is you go to the community and say, who wants to do this? You talk to them.
And sometimes that's the way that, I'm sorry.
And if it's huge leader turnover, I should say, I would actually look at the volunteer coordination, because it may be that you're asking people to do too much.
And I would say, too, that it's a nice way to connect sometimes with a practice. Like, say, if they can sell the idea of the CDSME with their patients, you might actually get some people that work at the practice that provide, that lead the workshop.
Yeah, we have several medical assistants that lead the workshop, for example.
Right. And has there been much use of CDSMP in federally qualified health centers?
Yes.
Yes.
And do you all know if those centers are experiencing similar results to some of these national studies in terms of the evidence, some of the outcomes?
I believe a couple of the sites in the study I showed you with 1,000 people were federally qualified health centers. And by the way, we did not see much difference between sites.
Does California or other states have an equivalent organization to No Wrong Door in Virginia? I don't know if anyone knows that. I think other folks on the phone were interested in learning whether there's a No Wrong Door equivalent in Texas and California and a couple of other states.
Yeah, there are other states that have No Wrong Door. It's actually a global term for the system that different states have, not just Virginia. What varies is what kind of tools are used, the software that's used for the system.
Great. And April, do you know how folks can go about finding out more about that global program or the
How
program
long door?
states? Mm-hmm.
I think it depends on each state. In our state, it's coordinated at the, our agency, the State Unit on Aging, but it does vary state to state. My goal is on door in the state.
And this is Christy. It's actually ACL it manages that program at a federal level in coordination with CMS and the Veterans Health Administration. So there's a website. It's nwd for nowrongdoor.acl.gov, and you can learn more there.
What are the differences between health coaching and CDSME?
CDSME is a very set program. It's exactly the same every place it's given. Health coaching is basically the health coach finds out something about you, and based on what they find out about you, they make recommendations and they work with you. So it's one-on-one as opposed to a group. It also is more it's more focused on tailoring as opposed to helping the person do what they want to do. Now that's probably cutting it too fine, but there are distinct differences. The other difference with health coaching is that because it's one-on-one, you don't have the benefits of the modeling from everybody else in the group, nor do you have the benefits of the peer pressure when everybody else is doing something. So there's a lot of differences, and we could talk all day about it, but those are some basic ones.
And Dr. Lurig, the CDSMP website, referring to the Stanford Education Program, someone was wondering, is there a new website to view information in education programs?
Absolutely. SelfManagementResource.com. And it's on both my slide and Christy's slide, so if you get the slides, or if you put in Self-Management Resource Center and put chronic disease self-management, you'll find it.
Great. And then someone was also wondering, are the programs pretty widespread around the United States? I know there was a map with the locator that we presented. This person's interested in finding a program near him as he or she is a crisis case manager for mental health crisis team.
Yes, just go to the locator and see. I can't promise you that they're absolutely everywhere, but I believe that we have programs in every state at this point. Obviously, some areas are better served than others, but go to the locator and you should probably be able to find an organization near you.
Mm-hmm. And if an organization is offering a program that's not listed on the locator, how should the organization go about making sure that it is updated in the locator? The only programs in the locator are programs of members of the Evidence-Based Leadership Council. So the way you do that is become a member of the Evidence-Based Leadership Council, and at that point, it would go in the locator. Great. Can you clarify the costs, if any, to the participants in the program? Given the state level support for CDSMP in Virginia, is it included in the state budget for DARs or area agencies on aging?
We're talking about charges to external sources for workshop participants?
I think cost in general, and then also to, participants, external sources if it's a plan.
The cost in general we found is, averages around $250 or so per participant. We don't charge, again, right now. Individual programs have sometimes asked for contributions, and they can charge. And we have tried to get it into the state budget, and the governor has supported that, but that hasn't gotten through.
And this is Christy. To add to what April said, I think it's important to be clear that these programs aren't free of charge. In many states, they may be subsidized by a federal grant or underwritten by a contract, but that there's certainly a monetary cost and value to these programs. And typically, though, we haven't seen the full cost passed down to participants. Sometimes it's just a nominal fee, but I'm not aware of any circumstances where the participant themselves has paid $300 or $350. That's typically either underwritten by a grant or is included in a contracted rate.
We will compile questions and answers and post these on our Resources for Integrated Care website. In case we're not able to get a hold of Kate here. But one last question. I know we have a lot coming in just, in the event that we can't answer all of them. Again, we'll post these on our website. But can anyone speak to the background of leaders conducting these workshops?
A leader needs to be somebody that's comfortable speaking before a group. They don't have to be an expert, but they can't be terrified about speaking before the group. Preferably, they have a chronic illness of their own. They get on with life without making the illness the center of their life, because we don't really want to hear about everybody's aches and pains every instant. They have the time to do 2.5 hours a week for 6 weeks, preferably twice a year. And they are able to follow the fidelity of the manuals without kind of adding great amounts of their own stuff. So I think, and finally, they represent the community that they're teaching. I think those, for me, are the biggest characteristics. Other people may have some others.
Thank you. If folks have additional questions or comments, feel free to email them to ric@lewin.com, and we'll add it to our list of questions that we'll post on the website. I think we can probably end a little bit early, but a few last reminders before we conclude. Slides for today's presentation, a recording, and a transcript will be available on our Resources for Integrated Care website shortly. A huge, huge thank you to all of our speakers, and thank you for everyone for attending and participating. At the end of this webinar, a survey will appear on the window behind the presentation. Your feedback is incredibly important to us, so please submit your survey. We'll take your feedback into consideration as we plan for future webinars. So thank you, everyone, for your questions. Thank you to our speakers, and have a good rest of your day.